This week on the BackTable Podcast.
I found setting time boundaries on a grander scale in terms of time blocking is really helpful. And so just like Raveen, I try not to do any charting at home unless it's a dedicated time. I do all my work at work. I make my office very comfortable. There's snacks, there's drinks, so I can get as much work done at work as possible so that when I'm home, I'm home. So having that mental separation between work and life to me is very important because our job is so overwhelming and so infiltrative.
All right. Hello, everyone, and welcome to BackTable Urology. This is a collaboration with the Society of Women in Urology. And today we're going to be talking about considerations for the early career urologist. I'm really excited to be talking about this topic today. I think it's something all of us early in our career experience, but we don't spend a lot of time talking or thinking about. And so in order to get this conversation going, I'm very excited to welcome two very esteemed guests here with us today. The first is Dr. Raveen Syan, who is the Director of Female Urology and Associate Professor of Clinical Urology at the Desai Urology Institute at the University of Miami, where she serves as the Assistant Program Director for the Urogynecology and Reconstructive Surgery Fellowship. She specializes in female pelvic medicine and reconstructive surgery, treating conditions such as incontinence, pelvic organ prolapse, as well as neurourology. She's a dedicated educator and researcher committed to advancing women's urologic health and mentoring the next generation of urologists. And Dr. Syan has been in practice now for 6 years. You're in your 7th year now.
Yeah.
And I'm also delighted to welcome Dr. Helen Hougen, who is a urologic oncologist who completed urology residency at Oregon Health Science University and a Society of Urologic Oncology Fellowship at the University of Miami. She's now in her 3rd year as an attending at the University of Iowa and practices the full breadth of urologic oncology with a clinical and research focus on bladder and prostate cancers. She believes in leading her teams with competence, compassion, and integrity. So welcome, ladies. I'm very excited to be chatting with you both this evening.
Thank you. Thanks for having us.
Of course.
So Helen, I know very well because when she was a fellow, we used to obviously bump into each other all the time. We collaborated on cases sometimes, and we chatted always about the challenges of being a female in urology. And so it's really nice to sit down and kind of formalize those conversations.
Yeah, absolutely. So I think, Helen, we'll get things kicked off with our first question, which is, what do you think makes the first few years of practice challenging? And what were some processes or systems that you developed to address some of these challenges to help you grow and thrive?
Absolutely. I think when we start as new attendings, we get a lot of advice. We get a lot of advice about, research. How do you schedule your research? How do you protect your time? How do you prioritize your clinical practice? How do you grow your practice? And many times these advice are often conflicting. I started writing down the advice I would get from mentors and senior colleagues. Some would say you have to get your research established in the first few years, otherwise you'll never get to it. Others say you have to get your clinical stuff down, otherwise you won't have the mental space to do research. In terms of complications, I remember hearing, you have to avoid complications at all costs. You have to be a safe surgeon. You have to avoid complications, even if it means sacrificing other things. Others say, if you want to make an omelet, you got to break some eggs. And putting all these advice together, I really had to think about why are the first few years of practice so challenging? And to me, it's completely multifactorial. You often have a new life. You're often moving to a new place from where you're training. You have a multitude of clinical challenges with a volume and intensity of decisions that you've not faced before in training. If you're at an academic center, you're teaching for the first time and you're building research for the first time. That is a huge number of things. Even without the new job, just the relocating and reestablishing a new life and a new place is very different. For example, I trained, as Raveen mentioned, at Miami, where I did my fellowship for 2 years. There, I lived a very carefree, childless life. I lived on South Beach. I dined al fresco on the weekends, and I had a really nice fellow life. And when I moved to Iowa, I became a mom, moved closer to my in-laws, and felt the culture shock of living in the Midwest for the first time. And for many, life does involve relationship changes. You're moving, you're potentially buying a new house, you are getting used to a new part of the country. And even without the job itself, that's completely overwhelming. And then to add to the intensity of our job, including the volume and the intensity of decisions, patient selection, treatment counseling, logistical decisions, you have developing clinical technical skills, and there's also getting used to institutional habits and practices. That in of itself, I think all of it put together makes it for a very overwhelming kind of transition from training to practice. And in terms of systems, I can spend a lot of time talking about it, but I think putting the process and dividing it into compartmentalizable pieces of, first of all, you have to survive. You have to survive all these decisions and transitions, and then you have to grow into an attending that you want to be. I think developing systems to understand how to survive your first few years, setting short and long-term goals, develop systems for work to maximize efficiency, developing boundaries to protect these systems, and then importantly, identifying and using your tribe of support are all things that I use to survive. And I'm happy to elaborate on any of those items. And then we can talk about how to grow and thrive as attendings as we continue in our practice.
Yeah, thanks so much, Helen. You're right. There's so many things that go into that transition. And I think one thing the three of us have in common is that we all are currently practicing at sites where we did not train. And so really it's like moving to not only a new location, we're working with new people, we're getting to know a new system. And so there's just like a lot of unknowns and things to adjust to just outside of the job itself. And so one other question before I head into Raveen, but Helen, you mentioned there are so many different pieces of advice that you did receive, but was there anything that you really wish something someone would have told you when you first started?
I think the most useful piece of advice that many of us hear that I still find extremely helpful is to find your support, find your network, and find your tribe. And that is one of the key aspects in surviving when you're at a new place. And identifying the tribe is not necessarily easy because there are multiple teams within that tribe. For example, I'm a urologic oncologist and I have different teams for my clinical work. I have a team that I found for example, big nephrectomies with thrombectomy. So I have liver surgeons identified, vascular surgeons. If I have to do a big reconstruction case, I lean on my reconstruction colleagues here. When I am finalizing and finessing a technical aspect of a surgery, I have folks here in my department who I can lean on. So that's the clinical team that I have here. I think leaning on your mentors from training is extremely important. I have my fellowship director and fellowship mentors, and also my residency mentors who I know I can call anytime. And even last week, I had a case that was really tricky. And I know if I called my fellowship director, Dr. Mark Gonzalgo, he's going to pick up and give me a thoughtful response. And having that in my team has been extremely helpful as I'm starting and continuing my practice. In addition, your family is an important part of your tribe. I'm very, very lucky to have an extremely supportive husband and a wonderful son. My husband has supported me through the hardest times of training, but I also think your family can only support you in so much, in that when I was beginning my practice, I would tell my husband everything that happened that day, including the really tough struggles. When I had my first major complication, it was all I could think about, all I could talk about. And one day, my husband, Gary, looked at me and said, "Helen, I can't listen to you talk about work anymore." And it's completely true in that he was doing the lion's share of our childcare. He was trying to keep my son Luca up at night so I could see him when I came home late. And it was a really tough work for him to be essentially a stay-at-home dad and a single dad while I was beginning my practice. And so importantly, I found a very important pillar in my tribe, which is my therapist, psychiatrist, and professional coach. After having my first major complication, I went to our hospital's employee assistance program, and they referred me to this professional coach who has really helped me in terms of talking to me about how to prioritize, how to think about some of the struggles I was having, whether it was clinical or relationship. And also, she also happened to know and understand the inner workings of the university because she has been there for a long time. And so working with someone who you can develop a professional relationship with, but also who deeply cares about you, I think is the key to this supportive relationship. And as the psychiatrist and professional coach, she has helped me identify my struggles and develop many of the systems I found that helped me survive and thrive. And I credit my team and also my coach very deeply to being the attending I am today.
Yeah, thanks, Helen. I can relate to that feedback from my own husband who early on when I would share a lot of my stresses and complications said something very similar, like you need to find someone else to talk to about this. So I think it's great that you really leverage the resources, at your institution and really recognize that and acknowledged it and, found, coaching and therapy and all of those resources that can be helpful. Raveen, I'd love to hear from you a little bit more about kind of what your first few years were like and a little bit about how, especially as you're getting started and have all these new opportunities, what you also did to kind of, set boundaries for yourself and deciding what to say yes to, what to say no to. So tell us a little bit more about that.
Yeah, so I did have a pretty different experience from Helen. I started slow. Benign urology is a slow build. And at our university, it was COVID. There was just a lot going on. So my practice started really slow. And I actually found that a challenge. We go from running 1,000,000 miles an hour in med school, residency, fellowship, and then all of a sudden we got all of this time on our hands, and I really struggled. I had anxiety from having too much time. So one thing I did do is I really focused on research. I had the space and the time to do so, and it was just a very different opportunity for me than I think it was for Helen. But I had the time to sit with ideas, cultivate directions of what I want to pursue, organize my research. And so that's really what I did with starting out. And that really helped me feel a little bit better prepared for the unknown, because I think that's essentially what Helen's saying. And I think is what's so hard about being a beginning is you don't know. You don't know what you should do, what you shouldn't do. You don't know which way your career is going to go. And so you're just hoping you're making the best decisions you can with what you have. So that helped me. I tried to be really productive with my time. And then, I got really busy, but it worked for me because I'd have built a kind of foundation and groundwork of my research, what I wanted to focus on and things like that. One story I always give, especially medical students that I mentor, because so often the question comes up about family planning. And so for me, I had hoped I'd have kids in fellowship. It didn't work out for me. And I actually entered this new job 3 months pregnant. And I thought it was the worst timing. I was like, I can't believe I'm starting a new job. I'm going to be starting and then slowing down and then trying to start back up. And it's kind of a mess. And actually, it was perfect. It worked really well because, again, like I said, things were pretty slow. So I was just slowly growing my practice. I left for mat leave and then I came right back and it kept growing. And so one thing I would say is you have to kind of lean into what happens in your life. And what seems like it's, a terrible situation or maybe not even terrible, just not ideal, you can really make it work for you. Or you can have the perspective that it was, beneficial for you or at least it got you to the next step, whatever that next step is. In terms of boundaries, I always find that question funny because I think managing boundaries is like a lifelong, skill or effort, right? Boundaries with ourselves, boundaries with our patients, boundaries with our colleagues, boundaries with our spouses, our children. I do think what I feel affects my boundary making is what's literally going on in that moment. So at some points in my life, I have more flexibility, say for, in the example, I was giving research. So I had less boundaries, right? I put more time and effort and energy into that. But then as clinical stuff got busy, I started setting boundaries. So I said, okay, I can't be up late at night doing what I used to do. So instead, I have a wonderful boss. And so I had dedicated research time, and I really used that research time to get my work done. And then I used my clinical time to get my clinical work done. So I've been lucky to be able to separate those two kind of neatly because I have protected research time. That's not always going to be true. And trust me, if you'd asked me this 2 years ago, I may not have had this perspective, but it's the perspective I have now. And then in terms of like other things like saying yes or no, I think that's really hard. I think that, and I hate to say this because I'm not sure it's the best advice, but I can only give you the advice that I've experienced. And so for me, I said yes to everything early on. Now, I had the capacity. I'm really emphasizing that my career started slow. My first few years were slow. So I had the capacity to say yes to everything. And I found it really helpful. I found like it just created this foundation of like colleagues and effort and energy and directions. So that when I started to get busy, I'd already kind of cultivated it. I've already learned to manage it and be efficient with it. So for me, it was helpful for me to say yes a lot in the beginning. I'm really practicing saying no now, though, because, at some point, first of all, there's opportunities that younger people, I'm starting to get mid-career, so I should say no to some of these things that some of the early career people can get involved and not monopolize. And then also, you kind of realize what you actually care about versus what you don't. And I don't think I knew exactly what I cared about when I started. So by saying yes to everything, I got to kind of sample everything and then make a little bit more of an intentional direction on what I liked and what I didn't like. But I think that's, boundary setting is going to be my lifelong challenge. And those boundaries are going to shift every minute, every day.
Yeah, I think you're right. There's never like a, clear boundary, but it's nice to kind of know where your limits are and then know where to set them.
I would echo what Raveen said in that I think it is important to say yes to a lot early on. And we always say, oh, no is a complete sentence. That's one of the advice that you get. But like Raveen said, you don't know what things will turn into unless you really try it. And I think one thing that can work is you can still lay out the boundary. If someone offers you something, say, oh, this is something that I'm very interested in. I will give it a try, and we can see how things look in a few months. I may or may not be able to continue, but I would definitely appreciate this opportunity and take advantage of this. I think that is really important because, again, we don't know what research will blossom, what clinical skills and techniques will be really important down the line, and what relationships you develop either with a mentor or a mentee that will really become fruitful.
Yeah, awesome. I wanted to spend a little bit more time talking about mentorship and how you both went about, finding mentors and allies when you first started your job, and what advice you would give to, other people just starting out.
Well, I think the thing about allies is people will serve many different roles for you. So don't have a limit on who's going to help you or be your ally, be your mentor. So my ally, my very specific ally, was my partner, Katie Amin. I mean, we started at the exact same time. We have the exact same practice. We have the same treatment rhetoric. So she was like a very direct ally, 100%. But, your peer is not exactly a mentor. So originally, I did feel a little bit like, especially when it came to SWIU and AUA, SWIU is, our organization that's important for female urologists. I just felt like I didn't have a lot of specific people looking out for me, pushing my name forward. So I actually just found the courage to reach out to, in this case, a few years ago, Anne Cameron, who was very clearly a leader in these societies in SWIU. And I met her at AUA. I just emailed her. I said, can I sit with you? I'd just like to, get some advice. And she was amazing. And she sat down with me and she said, okay, I'm happy to mentor you. It's just, remember, if I give you something, you got to do it well, which I also really appreciated. I appreciated her being like, listen, it's a two-way street. So I love that. And it's been really fruitful and awesome. And I have learned so much from her, and I got a lot of opportunities. So I think sometimes you just got to directly reach out. You got to have a thick skin and be okay with the answer being no, or maybe not getting what you hoped out of it. I'm fortunate that wasn't my, experience. But sometimes you just got to get out there and ask. And, it's hard, but just do it. And the worst case is they say no. You've literally lost nothing. You've only potentially gained something. And then I also talk about this. I think in medicine, we tend to think that medicine is not like a normal job. But medicine is also a job. And one of the things that I think people forget is you have a boss. And first of all, your boss is hopefully a mentor. Secondly, you want to keep your boss happy. And so for me, I had, Dr. Parekh was my chairman for many years. He just recently stepped into another role. But in the beginning, I turned to him a lot. And part of what I just turned to him was to understand what he wanted from this department and what direction did he see. And then, those conversations just naturally led themselves to mentorship and direction. There's a little bit of luck in that. But I do think it's important to turn to, your boss, your chair, and have that foster that relationship. And then maybe you'll find out, the boss's direction and vision doesn't align with you. And then maybe you need to reconsider, is this the right fit for me? But if it is a fit, that's someone you should really turn to. I think we tend to be scared of our chairs, and I'm still scared of him, but I still, I put on my big girl boots and I really tried hard to form a relationship, and I found that extremely helpful.
I think what my experience has been with mentorship is I didn't have someone specific. What I would hope for is someone who is in my department, who was maybe mid-career, who had similar experiences to me and could really lead me through the ins and outs of the hospital, leadership roles, research. But then as I continued in my first year or two, I realized there was not that one person, but you had to pick and choose specific parts of each person to be your mentor. So for example, I had a few clinical mentors who taught me a lot of important clinical skills. I had a few research mentors, including some folks who are not in my department who run clinical trials, who did really good quality of life studies through the Cancer Center. And in addition, I sought out a lot of other books in terms of how I could make better clinical decisions. This was more in resources that I found helpful. One thing that I found really helpful was the writings of Annie Duke. She is a cognitive psychologist who used to be a world champion poker player. And when I was struggling with some of my clinical decisions, I found her writing very helpful because she writes about clinical decision making and she writes about decision science. We make countless decisions in our jobs, and her writing has influenced how I make decisions. And specifically, she has this concept called resulting, and that really improved some of my decision-making process and helped me relieve certain decisional angst. Resulting is a cognitive bias where people judge the quality of a decision based on the outcome rather than the information and the process used to make in it. And so Annie Duke would argue that good decisions can sometimes lead to bad outcomes due to luck, other extrinsic factors. So evaluating decisions based solely on results can lead to poor learning and flawed thinking. And so she divides decisions and outcomes into these 4 quadrants. You can have good decisions and bad decisions, and you can argue in our field there's good technical inputs and bad technical inputs, and also outcome quality. And so if you make a good decision and a good outcome, that's great. It's an earned reward. If you make a bad decision and there was a bad outcome, it's deserved. You should analyze everything that goes into it. However, if you make a good decision but have a bad outcome, maybe there are factors in it that were out of your control, and you can maybe put that one out of your mind in terms of how you can change, because maybe there are things that you could not have changed. Or if you made a bad decision and had a good outcome, it's dumb luck, and you should still analyze the inputs. So this is not quite mentorship, but I found this thought process really helpful in relieving some of my decisional angst in some of my clinical outcomes.
It's really interesting. I've not heard of that. Well, let's talk a little bit about that, kind of those first few years and that decision angst and complications and dealing with a little bit of that stress? Helen, you touched on that a little bit, talking about a complication, that led you to, seek help and guidance from others in your institution. But Raveen, do you have any thoughts or input on kind of how you've managed complications or your thought process when thinking through them?
Well, I have to admit, I was lucky that I didn't have big complications until I was already feeling a little bit more confident. We have an amazing department, though. Our department is super collegial. We call each other into the OR all the time, especially in the beginning. Katie and I operate on the exact same days, so we're always popping in and out of each other's ORs. So I never felt isolated. That's definitely luck. There's also, I obviously fostered relationships with my colleagues and my friends. And I also, had the humility to not be afraid to just be like, hey, what do you think? What's your advice? I need help, which sometimes that can be a big barrier, right? Like we're taught to be so independent and in control and know what you're doing. But like, the reality is sometimes we just need a hand. So I was very lucky in that way. Any early complications felt like I had a team with me and I wasn't alone in it. And then, it is trite but true that if you don't have complications, you're not a surgeon. I mean, it's just part of it. And it's hard. It's very hard. But sometimes there's also a little bit of a relief. Like when you're dreading, oh, I hope this thing doesn't go wrong with this case that I do. And then it finally happens. And then you can kind of just breathe and be like, okay, I survived that. And so if it happens again, I know what to do. And for me, there was a little less, like it kind of alleviated my anxiety to have some of those complications that I just fixed and handled and moved on. There are some that obviously, you wake up at 2 a.m. thinking about it often, and you'll probably spend a lot of your life doing that. And that's just part of being a surgeon and caring about your patients and the outcomes. But I recently read something and it was talking about how surgeons need to look at their bad outcomes. And there's a few ways to look at it. One is, take a minute to just acknowledge to yourself, hey, I'm glad that I'm the kind of person who cares about my patients and how they did. And you either, a little bit like what Helen was saying, you try your best to learn from the mistake. We also got to be really careful not to hold on to that mistake when it was just, stuff just happens. Things go wrong. If you internalize too much, then you're just going to find yourself unable to move forward. So yeah, I guess that's sort of how I have dealt with it. Turning to colleagues, getting advice, not letting it be internalized beyond just making sure I do better if there was something that I could have done better.
In the beginning, I tried to prioritize certain goals, and I felt that really helped. When you're starting out, your overall clinical goal is to have a good outcome, but how do you prioritize that within the overall goal? And so as a urologic oncologist, I had a few tiers of goals. So my first priority was to minimize short-term complications such as unrecognized injuries, fascial dehiscence, early post-operative deaths. That doesn't happen as much in FPRS or ERPs, but these are realities as a urologic oncologist. So that's priority number one. Then my second priority was to optimize my oncologic outcomes, get my margin rates good, get my recurrence rate as low as possible. And then my third priority was to minimize long-term complications, strictures at the ureteral ileoanastomosis, etc. And then my fourth outcome was to optimize functional outcomes and quality of life, such as continence after prostatectomy, erectile function, stomal issues. And then my final priority was really to decrease time. And that really comes after all of the other things. So I think having that set of priorities and understanding what's important to your patients has been really helpful in terms of what I wanted to prioritize. Because like we talked about in the beginning, there are so many decisions that you have to make, and prioritizing these decisions and setting goals is really helpful.
Yeah, I think I agree with all of that. I think when I first started off, I really ascribed to the, starting like with, a little bit smaller cases in the beginning and kind of working up that level of confidence. And I know depending on what your subspecialty is or how you practice, sometimes maybe you don't feel that way, or maybe that's not practical, especially in oncology, right? You have patients who, may need, a big whack surgery to get that, definitive outcome that you're looking for. But I like to start with those like smaller wins and kind of build up my confidence. And then, but to Raveen's point, it's kind of nice to almost encounter that first like complication or thing that you've like feared so much, and then realize like, wow, it didn't defeat me, like I was able to overcome it. And then when it happens again, or if it does happen again or something's, a slight variant of that or a different complication, you're able to continue to learn from that and move it forward. And I think, it's just like all those little like, you start to build like little scars that kind of help like toughen you up, or calluses, I guess, one way to look at it. But I think for me, it was helpful to kind of like build a little bit of like baseline confidence. And then at least when it came to operating in clinical practice, and then, start taking those like bigger bites as I went along.
Absolutely. Aristotle had this, there's this Atlantic article about 10 keys to happiness, and it's Aristotle's 10 points to be happy. And the first one is bravery. And I think having the courage to do something and to face the consequence, especially if it didn't go well, I think that builds up yourself and allows you to be brave down the line, to build that confidence, like you were saying, Michelle, and allows you to achieve greater satisfaction in the next cases that you do.
Right. And so one other question, as this is, part of our collaboration with the Society of Women in Urology, and we're all women here talking today, about early starts to our careers. Do you think there's any, have you observed any differences in how sort of men and women launch their careers, and anything that's advice you would specifically give to, women, starting out?
Helen and I actually talked about this before the episode, and it was interesting. We both came to the same. I don't feel like I had less opportunity because I was a woman. I think I had less opportunity because I'm a benign urologist. I mean, the urologic oncologists get the most respect, the most opportunity. The chairs tend to be oncologic, and so they have more, ability to push you forward. And I think that's really the challenge for me. I don't think it's my gender at all. I think it's my subspecialty. And it's hard. It is, you watch your onc colleagues progress at a much faster rate or develop these bigger names sooner. But I also don't have to worry about the 4 hierarchies of complications quite as much. So maybe there's a trade-off. I don't know.
It's a balance.
Limit this, limit that. And then, I think, I found it helpful to not let I did not perceive it to be, and I don't think it was, my gender issue. So instead I turned to other things that I could solve, which is, mentorship. So reaching into the societies to find people to help me, turning to my boss, turning to my colleagues, touting my name and pushing my name forward, signing up for those millions of emails that you get from AUA or SUFU saying, oh, consider or apply, and just apply, reject until finally, you get something. So that's it was an interesting topic, conversation between Helen and I, but that's what my experience was like, or it still is like, honestly.
Absolutely. I would agree with that, in that as an oncologist, even starting out, I had a ton of resources because my, clinical time, whatever RVUs were valued. I also had more kind of resources for research through the cancer center. Of course, I do think there are differences between how men and women are treated. Are those things, can we work on them? Maybe, not always, but I think ultimately, if you are just very genuine as yourself, you try to be predictable when it comes to interacting with your staff, try to always be kind, perform your job and lead your team with integrity, that's all you can do. And that's always the best you can do.
All right. So then thinking about, balance, how did you both balance patient care with other aspects of your job and also your life outside of work when you first started out and now?
Well, I think for me, in my 7th year, the one thing I can say that was always true is the balance was always shifting. I mean, what you have the bandwidth for, what your opportunities are, what's going on clinically or in your life changes. So I think, and I think I've been kind of giving this theme, but you kind of got to be a little bit, day to day, or maybe that's too narrow, but like month to month or year to year, that what you need to focus on is going to change from year to year. So, early on for me, something simple like I didn't like to chart at home. I would forget what I said to the patients, or I just wanted to hang out with my kid and my husband. So I just got extremely efficient with Epic UChart. I have a trillion dot phrases. My colleagues make so much fun of me, but I can close the chart before I even leave the room because I've dot phrased every single possibility variation of what I want to say to people. And then, as I alluded to in the beginning, I focus more on research in the beginning. These days, I'm focusing more on clinical, and the amount of time I have allotted to each has changed every year. So I think you just have to see what's actually important for you right now. And I do think, and I'm glad to see that most people these days seem to have that mindset that but first, take care of yourself, your happiness, your family, because ultimately that is our core, right? That's where we actually, work can be amazing, but if things are not going well, either for yourself mentally or physically or with your family, work's never going to feel good enough or enough to carry you through those challenges. So I had some little rules and I still mostly follow them. I'm breaking the rule right now, but usually between 6 to 8 is my kiddo time. So I hang out with my kid, my husband, I have dinner with them, we do bath time, and I really try and avoid booking anything. Of course, there's exceptions like this. There's many times that I don't do that. But by making the effort, it just actually made me really happy. It gave me, every day I know what to expect on those hours. This is what I'm doing and it makes me happy and it gives me consistency. Helen kind of alluded to this, but we all went to new cities. So that's its own unique challenge. You got to be willing to put yourself out there, make effort, do different things. Very recently, I am really obsessed with this sport called paddle, and it's been the best thing ever. I've made so many friends and huge new community and a new energy and effort for me. But you kind of got to step out of your comfort zone and do something now. It doesn't have to be paddle, but the idea of that you have to go seek a new community to also give you balance and, happiness, really.
Yeah, I really echo Raveen's time boundary when she is setting aside time for her son. I also block out 6 to 8 p.m. for my family. Try to make it home for dinner, try to be there for bedtime. I also block Saturday mornings where we go to the farmer's market and hang out and have lunch. And those are just times where my family knows I'm always around. And I think having that predictability is very important, and setting good expectations with your family so that they always know these are times when mommy or wife is here and there's less anxiety on both our parts. Along with that line, I found setting time boundaries in a grander scale in terms of time blocking is really helpful. And so just like Raveen, I try not to do any charting at home unless it's a dedicated time. I do all my work at work. I make my office very comfortable. There's snacks, there's drinks, so I can get as much work done at work as possible so that when I'm home, I'm home. So having that mental separation between work and life to me is very important because our job is so overwhelming and so infiltrative. I found this book called this mini online book, which if there are show notes, I'm happy to link to. It's called Personal Productivity, How to Work Efficiently in the Midst of Chaos. It was written by an OB-GYN actually out of the University of Iowa. And she was a professional coach at the institution. And she talks about many systems that you can put in place to block out your time, set your to-do list in small bite-sized ways that can maximize your efficiency at work. And to me, that's really the key to setting good balance. You have to work at work so you can be at home at home.
Yeah, this is all very helpful advice and very practical. I think all of us, it's really helpful to set those boundaries between work and home and be able to spend that quality time with family, friends, and, doing the things that bring us joy outside of work as well. So another question, I think we're all fortunate to still be at our first jobs, but what would be some reasons that it may be time to leave our first job?
That's a tricky one. I have not thought about that, in that I'm very content with my job. But when I first started my job, one of my senior colleagues here handed me a PDF called Understanding the Academic Medical Center, Simone's maxims. And one of the things that it talks about is academic institutions won't love you back. And you know it's time to leave when the pull from somewhere is stronger than the push. To me, if I imagine leaving, it needs to be something better instead of something that is pushing me out. And so if there's something that's not good here, perhaps in my maybe naive way of thinking, I would try to make that better instead of having that push me to a different place and do potentially a lateral move. I don't have experience in this, but that's how I would imagine the process being.
Yeah, I mean, I look at, so in my number of years here, I've had some of my colleagues move for various reasons, sometimes a better job opportunity, and sometimes the culture fit was wrong. And I think that's really important. It's okay to find a new job if the chair's vision, the department's vision, the culture is just not a good fit for you. Like 30% of people switch their job in their first year. So, the fear of switching, that alone shouldn't be the reason to stop you. Now, obviously, it takes courage and it's scary, but I do think feeling like, the way the department's going, the direction, the vision, if that doesn't align with you, I would say that's probably a good reason to want to leave. And I can speak to the colleagues that did leave that for several of them, that was the issue. They didn't align with the vision and the direction. And I think that's okay. We're all human beings. We're all different. We're not all supposed to have the exact same ambitions and goals. And then I think the other thing is all of us in every job in the world have days where we want to quit. And so I think it's important to make sure if you're seriously thinking about it, you just want to make sure you're dissecting where the unhappiness is coming from, because we have many things that affect us and that can feel like, oh, it's work that's bothering me. But sometimes it's you're struggling with something mental yourself, or there's some external life issue that's creating a lot of pressure so you don't feel like you have the bandwidth for work or other things. And I think it's important to make sure, like when you make that decision, you're kind of dissecting, well, what is this really about? And if it's about work, get out of there. But if there's other things going on, it's really important to make sure you're recognizing what are those other things. I mean, Helen and I were talking, like everybody should get a therapist. A therapist is I say this to my patients, my IC patients. If you could afford a therapist, the time for a therapist, everybody should have a therapist. You don't have to be depressed. You don't have to be, mentally unstable. You're just looking for an opportunity to just handle the challenges of life and the chaos of being a physician in a little bit of a better balance. So, yeah.
I think that's really great advice. As we wrap things up, do either of you have any final pieces of advice to give our listeners?
Well, I would say when you listen to this, remember that we have our unique experiences. I mean, even though you listen to Helen and I, so some of these things are pretty different perspectives and experiences. So make sure you're just pulling out what's relevant to you. My experience is not going to be your experience. And so if something feels like, oh, well, why didn't I have this? Well, or why is this not something I have to worry about? Or why is she not talking about this concern that I had? We do have unique paths. So everybody's path is not going to be the same. But the beautiful thing is, like, Michelle's a very good friend of mine. Helen, I got very close when she was a fellow. You just turn to the people around you. And again, you make the best decisions you can with what you're presented with. And if you make a bad decision, well, you can always turn that around or redirect it to something positive.
Absolutely. I think what Raveen is saying is not everything works for everyone. And having that time to reflect is really helpful. This was a Grand Rounds talk by Angie Smith. I adopted that practice where every, month, she would set aside a block of time to just reflect. And she would block the time on her schedule. She would just think about her life and her research, projects, clinical life relationships. And I found that time where you just think and reflect to be extremely helpful. And I often reflect on the cycle of our growth curve. You're either, surviving different parts of your practice, you're growing, thriving, and that process is ongoing. And in the richness of our lives, the different components are often at different stages. Sometimes I'm barely surviving at home and really doing well at work, and vice versa. And I think in the first few years of practice, we will all grow so significantly over time. I really think these are the most important and fruitful times of our life. We all develop technically. We all grow as people, as family members, as colleagues, and there's always more to figure out. And I think to continue to be the rich people that we are, this cycle will just have to continue and continue. And that's what makes our jobs and our lives so great.
That's a really nice way to put it, actually. I like that.
Mm-hmm.
Well, I want to thank you both so much for joining me today. I think this was a really interesting and engaging conversation. Just want to put in a small plug. I'm not sure when this episode will be released, but for the upcoming Society of Women in Urology meeting, that's going to be held in Nashville, Tennessee this year at the end of January. So we hope to see many of you who are listening to this podcast there, and hope everyone has a really great rest of their week.
Thank you.
Thank you for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.